We're a little down the road now. So we missed the first a couple of slides. So I apologize. I think we about 4 slides. Missed about 4 slides. So, but the heart has to basically contract all in one fell swoop, right? It has to squeeze really tightly, really strongly, all at once, so that it can get maximum pressure on that blood, so it can squeeze that blood throughout the entire body. Okay, and the only way it can do that is if all those cardiac muscle cells are hearing the same contraction signal at the same time and responding to it at the same time. That is to say, they contract in unison. The only way you can do that is if they're all hearing the command at the same time. Okay? And that's the reason why you have gap junctions in there. Otherwise, they're connected by desmosomes, which are adhesion cell connections that kind of connects the cells together structurally. Okay, gap junctions aren't structural, they're communicative, and desmosomes are there for the structural connection component. So this is kind of what your heart looks like. You can see there's the surface. A couple of things I want to basically point out. First of all, is you'll see the heart proper. Here you can see there's a couple of main things, and I don't want to cover these because the chambers are best covered when we get to cutaway, which is going to be in a couple of slides here. But one thing I want to point out here is the vasculature around the heart. For instance, draining blood from the head and shoulders is going to be one of the main inlets to the heart, which is your superior vena cava, right? That's this big blue guy right here. And from below, from your trunk and your legs, is going to be the inferior vena cava coming from the bottom. These are both going to be draining into the right atrium, which is this guy right here. And then from the right atrium, it's going to move into the right ventricle. And then from the right ventricle, it will move through a set of valves into another major great vessel, this guy right here, which is the pulmonary trunk. This is on the sending the blood to the lungs. So basically, it's going to be moving through the pulmonary trunk, and it's going to split into the right and left pulmonary arteries as they go to the lungs. So here it's going to the lungs, for the right and left lung. And the job there is to dump off CO2, pick up oxygen, because it's going to do that gas exchange that we need at the lungs so it can get more oxygen. Then it's going to come back from the lungs in the pulmonary veins. And then from here, it's going to basically go into the left ventricle, the left atrium, which is this guy right here. And then from there, it's going to go into the left ventricle. And then from the left ventricle, it'll go through the aorta, which is this big guy right here, which is broken into the ascending, the arch, and the descending. Now, from the arch, you have 3 main branches. The first one in humans is the brachiocephalic artery. That's this guy right here. BC, brachiocephalic. So brachium is the word for arm, cephalic for head. So this is heading toward the right arm and the head. Okay, so that's where the blood in this branch are going. The middle one is the common carotid, CC. This one is going to become the carotid arteries. Okay, those carotid arteries are going to be the main arteries that supply blood to the brain. This is, by the way, the one that if you happen to have a neck injury and you nick the carotid, this is the one where you'll bleed out like within minutes. This is a very dangerous one to damage or to injure because it's a major artery. And then the last one is your subclavian, SC. This is your left subclavian. And this one basically goes to the left arm. So it goes basically up underneath the clavicle, which is your collarbone, subclavian, below the clavicle. And then it goes through your arm, down through your arm, and to your left arm. Okay. And so those are the major branches that are leading to and away from the heart. Those are important because those are servicing the heart itself. Now let's go ahead and take a look at the actual mechanical structure of the heart now that we kind of know some of the major vessels that are coming into the heart. let's take a look at some of the major structural components of the heart itself. First of all, the heart is surrounded by a parietal layer of membrane called the pericardium. So it actually forms a little sac. It looks like a little sandwich bag around the heart. So that's your pericardial sac. That's actually the part of the serous membrane system that is lining the cavity, the pericardial cavity. Within that, you'll have pericardial fluid, and that's for lubrication because why? The heart is constantly in motion. Right, so you have a little bit of lubrication in there to kind of reduce friction and chafing and scar tissue development. Internally, the heart is divided into chambers through walled structures called septum. So these are basically walled structures made of muscle called septum, and they'll divide the heart into right and left and also into top and bottom. So ultimately, your four chambers of your heart, you have two atria, and you have two lower chambers, the two ventricles, which we just kind of pointed out here a little bit. And so this is kind of what it looks like. So here you can see now the cutaway version, which is actually the better version to take a look at. And so one of the things I want to do is I want to lay out the pathway of blood through the heart, and then we'll kind of go through each little piece of this as we start to move forward. First of all, blood is coming through the superior vena cava and the inferior vena cava, and it's draining into the right atrium. So those are basically filling up that right atrium. Then what's going to happen is the atria are going to contract. And when the atria contracts, it's going to move the blood forward. And it's going to be moving through a set of valves called atrioventricular valves, or AV valves, that basically marks the boundary between the atrium and the ventricle. So it's going to be entering into the right ventricle. And then after that, once the blood is in the ventricle, then it's time for the ventricles to contract. So once the ventricles contract, the blood will want to naturally go backwards. It'll want to backflow back into the atria, but it cannot. Because what happens is when that blood in the ventricle is pushed against the AV valve closes, disallowing it to backflow. So it only has one way to go, forward. That forward direction then is going to go through a set of what's called SL valves, these sort of half moon looking valves. It's going to push that valve open into the pulmonary trunk. That's where you are now. And the right ventricle pushes the blood through the pulmonary trunk and then into the right and left pulmonary arteries on the way to the lungs. Once they exchange oxygen for CO2, they're going to come back from the lungs through the pulmonary veins, and they're going to basically empty into the left atrium. And they're going to basically fill that up with blood. By this time, it's time for the atria to contract again. So the left atrium will contract. It'll push the blood forward into the left ventricle, filling the ventricle up with blood. Then the ventricles will have their turn again to contract. And once they contract, they do the same thing. When they push the blood back against the AV valve will shut close, only allowing forward movement of the blood going through, in this case, another SL valve, which is hidden behind all the structure. But that's the aortic valve, which is right in here. And that blood will go, I'm going to put dotted lines, through the valve and into the aorta, up the ascending, around the arch, and then down the descending to the rest of the body. And then all the while, the blood will be shooting off these main branches to the head and shoulders. Okay. So that's basically the pathway of blood through the heart. This is actually what a real heart looks like. Now, one of the things I wanted to point out over here is that because the heart itself is a muscle, it also has the need to have blood supplied to it. These are hardworking muscle cells who do a lot of contraction. They need oxygen just like everybody else. They need nutrients just like everybody else. They need somebody to come and pick up their waste just like everybody else. But they have their own delivery system. And that's what all these blood vessels are on the actual heart itself. So when you take a look at the heart, you can see these major blood vessel groupings here, and here. So these guys here are basically what's referred to as the coronary system. So for instance, your left coronary is right here. And it branches into one that kind of skirts around underneath called the circumflex. And then it'll branch down here to basically what's called the anterior interventricular or the descending artery. And so this one is basically feeding your left ventricles. And of course, you'll have a vein that basically takes the blood away from it in the same area. This is called the left cardiac vein. Over here, you have what is called the right coronary artery. This feeds the right side of your heart. And it'll branch off into all sorts of different little veins, marginal veins, and so forth. But these guys wrap around your heart to basically feed blood to your heart and to also collect that blood from your heart. Okay, so that's basically what happens. Matter of fact, most of the time, and a lot of times people don't realize this, when you have a heart attack, the arteries that we're worried about in cardiology are not the arteries necessarily like in your leg and stuff like that, although those are certainly ones we want to keep an eye on. Typically the ones that we're worried about when we do stress tests on you and we take pictures of your heart to see how the blood is flowing through your heart, what we're worried about are these arteries and veins, the ones that are supplying blood directly to your heart. Because if these ones get plugged up and clogged up, then this will stop blood flow to your heart, which will cause heart attack. Okay. As a matter of fact, this guy right here, this big diagonal one, is actually mirroring. If you take a look at our heart picture, you'll see this big old piece of muscle right here. That is your interventricular septum. That separates the two ventricles into two chambers. That's like the wall between the two chambers. You also have an atrial septum as well, although it's a lot thinner. But the reason why I mention that is because this guy right here is the anterior interventricular artery. Anterior, front side, interventricular, between the ventricles. That means it's marking the septum. That's where that septal wall basically is right there where that AI. And of course, it's an artery. The reason why I mention this one is because this one has a notorious reputation. In our office, we had a nickname for it. We called this one the Widowmaker. Because if this one gets plugged up, you're in deep trouble, right? This is when you need to get into a cardiologist's office and hopefully they catch it in time. And they'll drop a stent in there and open it up. So this is one that you want to make sure you keep good and clear, because this one will have the effect of killing you. So let's go ahead and take a look at the structural components of our pump. First of all, the valves. The valves are critical in your heart. So you have two sets of valves. First of all, you have the semilunar valves. These are those half moon ones that we kind of looked at. They're very similar to the ones we saw in the veins, right? And then you also have what's called atrioventricular valves, or the AV valves. So these are the ones that look like basketball hoops, right? So the ones that separate your atria from your ventricles. The AV valves basically have what's called chordae tendineae. So this is basically the strings of the valve that essentially they're essentially bound to a particular portion of the ventricle called a papillary muscle. It's like a little extension of your ventricle. So if you take a look at your AV valve, you've got the hoop-like structure with the flaps, and then you've got the strings. So the strings basically are the chordae tendineae. So tendinous cords, basically is what that means. Okay. You have two different sets of them. So the left AV valve oftentimes will also synonymously be referred to as the bicuspid valve. Why? Because it has two flaps or two cusps instead of three. It is also commonly referred to as the mitral valve on the left side. As a matter of fact, when I still worked in the cardiology office, almost all the doctors there referred to it as the mitral valve. almost nobody referred to it as the left AV valve or even the bicuspid valve. The right valve is the tricuspid valve. There's no cute little nickname for that one. It's just a tricuspid valve because it's got 3 flaps of tissue that form the ring or the hoop. And that's just the name of the structural name of it. The semilunar valves, which is the next grouping. So these guys are going to be separating AV valves, are the ones separating the ventricles from the great vessels. So the pulmonary valve is the one that separates the right ventricle from the pulmonary trunk, and the aortic valve separates the left ventricle from the aorta. Okay, both of those are half moon-like structures. So the coronary arteries then are typically the feeders of the heart. So you have coronary arteries that supply it, branching off of the aorta itself. These are actually the first ones to come off the aorta, and the aortic and the coronary veins, which are draining the heart once it actually has spent blood back into the right atrium. As a matter of fact, if you take a close look, you can see sometimes the entrance of the coronary sinus here. So that little depression is the entrance of the coronary sinus where all that coronary venous blood is draining from the heart into the right atrium, because you've got your opening to the superior vena cava here and the inferior vena cava's openings down here. Okay, so you have 3 main openings coming into the right atrium. If you have a blockage of these guys, that's where you get your heart attack. That's myocardial infarction. Okay, and that's typically like when you go to your cardiologist to have your stress test done or to kind of have your basic check. A lot of times they'll do a stress test on you, and this is what they're looking for. They're looking for blockages anywhere in that coronary artery system in particular to see whether or not there's blockages in there if they have to do a stent. So the blood flow through the heart, basically, this is kind of, I went through this early, and going through it numerous times is helpful because it takes a little bit, sometimes to a few iterations to kind of make sure you get it down. But basically, it's going to be coming up through the inferior and superior vena cavas, typically going to be oxygen poor, CO2 rich, right? Because they're coming from the tissues. They just dumped off their oxygen, so they don't have a lot of that left. And they picked up a ton of CO2 from those active and busy tissues. So now they're going to be tissue CO2 rich, and they're going to be dumping all of their contents into the right atrium once the right atrium contracts. So this is going to be the first piece. The right atrium is going to contract. It's going to send blood through the AV valves, in this case your tricuspid valve, your right AV valve, into your right ventricle. Then the next thing that's going to happen is the turn of the ventricles to pump, and so the ventricles will then pump blood through the pulmonary valve into the pulmonary trunk, which will then go into right and left pulmonary arteries on their way to the lungs for gas exchange. Once they exchange gas, now coming from the lungs, they're now CO2 deficient or CO2 poor, and they're oxygen rich because they just basically picked up a fresh batch of oxygen and they dumped off CO2. So they just kind of flipped the script a little bit. And then those pulmonary veins are going to be bringing that oxygen rich blood back into the left atrium for distribution through the rest of the body. And then as the left atria contract, they're going to be sending that blood through the mitral valve, bicuspid valve, left AV valve, into the left ventricle, and then the ventricles are going to contract, sending it through the aortic valve, which is another semilunar valve set that goes into the aorta, and from there it branches out to the rest of the body. For instance, those smaller ones will be basically sent through arteries, smaller arteries to arterioles to capillaries and so forth throughout the rest of the systemic system. So basically, that previous discussion that we had about the going from the arteries to the arterioles to the capillaries to the venules to the veins back to the heart, that is basically what's happening here from the left side of the heart as it pumps it out to the rest of the body. Well, that was a lot in a short period of space, short period of time. Okay. So then, basically, when you take a look at passage of blood through the heart, you can basically separate the heart into 2 main kind of regions, if you will, left certainly and right. The left side of the heart has much thicker walls. Why? Because they're having to pump blood to the entire body. So they need a more powerful pump. They got to make sure they get all this blood, every little bit of it, all the way down to the nooks and crannies, right? To the tips of your toes, to the tips of your fingers. They got to get it all the way out there. And so they have to have a really strong push in order to make that delivery. The right side of the heart doesn't have to go very far. The lungs are just next door. So you don't typically need as much pressure from the right side as you do from the left side, which is one of the reasons why, if you take a look at a heart, like for instance, if you were to dissect out a sheep heart, you would notice that really what a heart looks like is a gigantic left ventricle, really thick walls, septum and lateral wall are really thick. And then the right ventricle is just like this little bitty thing off to the side. Right? So it's actually not even equal. Oftentimes in textbooks, we draw the chambers equally so that you can see the structure inside it. But in reality, it is a left ventricle dominated world. Your heart is dominated by the left ventricle. And it just basically, the right side just gives it a little squeeze, just enough to get it to the lungs. Right? So it doesn't have to go very far. Now, between the atria, it's even thinner than the ventricles, because the atria also don't need to go very far, right? I mean, the ventricles are sitting right there, just beneath them. So when those atria contract, they don't have to contract super, super strongly in order to get all that blood to the ventricles. So here's the deal. What you can see here is the structure is adjusted to meet the need. If you don't need a ton of musculature because you're just going next door, then you don't have a ton of musculature. It's just a little thin layer. Okay. So you have enough structure to do the job. You don't have extra structure, right? You don't get extra points for having more muscle when you don't need it, right? That's kind of a waste of metabolic money, so to speak, right? It's a waste of energy. And you got a lot of needs in your body, so you want to spend that energy somewhere else. Okay. So the pulmonary capillaries in the lungs will basically do the gas exchange. So your oxygen will enter blood at this point. Carbon dioxide is going to be expelled from the blood into the lungs so that you can breathe that out. And then that basically is kind of like your delivery system. So after you basically picked it up from the tissues, now you're going to be delivering that and getting rid of it from the lungs itself. That's the reason why you want to keep breathing, because breathing does two things. Number one, it gets rid of all your metabolic waste, one of which is CO2, two of which is water vapor, right? We breathe out water vapor because water vapor itself is a metabolic byproduct. Now, of course, at the same time, you're taking in oxygen. And so you're doing both things as you're breathing. That gets us to the idea of cardiac cycle. So in cardiology, typically what we like to do is we like to take a look and measure a heart, basically what the heart is doing in terms of its cycle. Like basically when we go through this atrial contraction versus ventricular contraction, and the way they contract, by the way, just to sort of dispel any confusion perhaps, is when your heart contracts, what contracts first is the atria. Both atria contract at once, boom, right and left at the same time, and sending the blood to right and left ventricles at the same time. Then what happens is as the atria are contracting, the ventricles will contract at the same time, right and left, boom, at the same time, sending it to the right side and to the left side. And so what you have then is you have atria, ventricles, atria, ventricles, atria, ventricles, like that, atria, ventricles, atria, ventricles, atria, ventricles, atria, ventricles, atria, ventricles, right? So that's basically your heartbeat. Now that cycle from one atrial contraction to the next is the cardiac cycle. It includes both the ventricular contraction in between. So from when the atria contract to when the atria are ready to contract again, that is one full cardiac cycle. It's broken into two main episodes. The first one is what's called systole. Systole is simply a fancy term for the contraction of your heart. This is the contraction phase of your heart. The second phase is diastole. This is basically a fancy term for the relaxation of your heart. Generally speaking, when you take a look at your cardiac cycle, your heart will basically beat, that is to say, roughly about one cycle, roughly 70-ish or so times per minute on average. Of course, there's a lot of variation to this, isn't there? If I give you guys a surprise exam, like right now, what's going to happen to your heart rate? It's going to stay all nice and mellow. Yeah, your heart rate's going to go like a lot higher, isn't it? Because I just stressed you guys out. Probably just even saying that is stressing you guys out, right? So your heartbeat will go much higher. If I have you guys just sort of relax and just sort of find your happy place, zen out a little bit, turn on some of your favorite music if you're an aromatherapy person, get your favorite smells around you, get your favorite music, whatever it is, just kind of all of a sudden what it's going to happen to your heart rate. It's going to go down, isn't it? Because you're kind of in a relaxed state. So there's a lot of variation to this depending on what's happening in your body. And so typically when you use a stethoscope to listen to your heart, you'll usually listen to your classic heartbeat, right? It's getting close to Halloween. I'm sure you guys can probably find a good horror movie that has some sort of a heartbeat in it, right? Or the sound of a heartbeat. Some of the more gory types of ones will actually have a beating heart in it, right? Check it out. There's like Indiana Jones, the second movie, right? But what is that heartbeat? Well, there's actually 4 audible sounds. There's actually a few more than that, but 2 of them we hear very strongly. The so-called, the classic lub-dub of your heartbeat, right? So you listen to your stethoscope, your heartbeat is going lub-dub, 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 right? Well, that lub and that dub is basically associated with different events that are happening in your cardiac cycle. For instance, when you hear that lub sound, lub-dub, what's happening is you're hearing the sound of your AV valves closing when the ventricles contract. Remember what we said? When the ventricles contract, the blood wants to go backwards, but it can't because those AV valves snap shut, disallowing them from going backwards, so they can only go forwards. Well, the sound of those AV valves snapping shut is the lub sound that you hear in your lub-dub. Now then, once you hear the dub sound, this is the closure of your semilunar valves. This is basically when they close, when the arterial blood tries to backflow. So think about it for a second. So here's our left ventricle. I'm just going to write left ventricle. So here's your chamber in your left ventricle. It's going to be connected to your aorta. So here's your aorta ascending. I'm going to go around the arch like this and then descending. So there's my aorta. Forget about the right side for now. I just want to focus on the left side. Remember, the SL valves are these little semilunar valves that we saw like in the veins. So what happens is when the pressure in the ventricle increases, it pushes the blood against that open valve, which basically squeezes it up in the ascending aorta. But here's the problem. Once that ventricle contraction comes to a close, it's no longer able to put pressure on that blood anymore, is it? It's going to stop putting pressure on it. What happens is the force of gravity and the lack of pressure is going to cause this blood to want to come right back down. And if there's not a valve there, it's going to come right back down into the left ventricle where it came from. But there's a valve there. So what happens when I push against that valve to try to come back in? The same thing that happens to us in the veins. That valve snaps shut, just like with the door. Once I try to push back against that door to come back in, the door closes on me and I can't get back in. That sound of the closing SL valves is the dub. That's your lub dub. Now, typically, some of you may run into a murmur. Some of you guys may have a murmur, actually. A murmur simply is when you're listening to the sounds of your heart, the lub and the dub. Typically, what you'll have is it kind of a gurgling sound, which is also times the reason I call this mitral regurgitation, a gurgling sound in between a lub and the dub. So it'll be kind of like a lub, dub, lub, dub. It'll be kind of a swishing sound or kind of a gurgling sound, depending on what's going on in there. This is because of a leaky valve, usually mitral valve. And this is the one that we're really worried about. Now, a lot of people are living with heart murmurs. Do you know anybody who's living with a heart murmur? Or mitral valve regurgitation? It's not necessarily a bad thing, right? Just because you're getting some backflow doesn't necessarily mean you're going to drop dead. It depends on how severe it is. Your heart can handle a little bit of backflow, just as long as it's not a ton of it, right? If you're doing one step forward, one step back, that's going to put too much stress on your heart. You need to get that fixed. right? But if you're doing mostly like, 3-4 steps forward, 1 step back, that's a little less severe. Most of your blood is moving forward. And if that's the case and you're able to meet the demand of your body, your heart's doing what it needs to do. A lot of times people don't even realize that they have this issue until they play athletics. Because a lot of times when you're just at rest, your body doesn't have a lot of demand because you're just resting. You don't need a lot, right? So your blood is fine if it's a little inefficient. But once you start moving into athletics, where you have a much higher demand, athletic demand on your body, and your body really needs all 4 parts of that blood, then that 1 step backward can be a dangerous thing. And that's where we see difficulty, where people are like, wait a minute, I just realized I had a heart murmur for the first time because you didn't do that much high level activity before. Rita.
Oh yeah, I was gonna ask, is that caused by like that?
Usually any kind of a valve pathology is usually congenital. Sometimes it can be induced. It depends. Like rheumatic fever, for instance, can create valve damage. So there are some diseases, toxins and things like that, drugs perhaps, that can create abnormality, structural problems with the valves themselves. But usually those sorts of things will create global problems with the heart structure. The valves are just a small part of it. A lot of people, especially people who are young and they're not taking drugs or they haven't had rheumatic fever, which is fairly rare these days. You don't generally get rheumatic fever anymore. Most of those are congenital. So they were born with maybe a slightly malformed valve, not catastrophically off base, but just a little tweaked, and they're at rest for most of their activities. Are fine. They're able to get enough blood. But if they were to like go into really high level training, it would start to cause problems. So most of that is probably congenital. So here's kind of what it looks like in terms of the pathway of blood going through the heart. So basically you're going to have your blood moving from the superior to the inferior vena cava, entering into the right atrium. It's going to then contract. The atria are going to contract. You're going to move through the AV valves, both of them at the same time, into the right and left ventricle. And so here you can see the ventricles filling up. And then once you're going to contract, you're going to get the contraction here. So these little lines represent contraction. So your ventricles are going to contract at this particular point. And as they contract, they're going to want to push blood against the AV valves. So it's going to snap them shut. And so as they shut, that's going to be your lub sound. And then in addition to that, once you see your semilunar valves at this particular point here in the first piece, before ventricular contraction, are closed. So the reason why I mention this is because this image right here is a really good image, because you can see this is your aortic valve. This is an actual real valve that you can see. It's basically closed. You can see the reason why they call them semilunar, half moon, is because the flaps, the cusps, are actually half moon shaped, and you got 3 of those. And so this is closed, so all the blood would be basically going down on top of it. So it's sitting on top of it, sort of causing it to snap shut underneath them. On the flip side of it, this one actually has a view of the mitral valve. Remember, that's the left side AV valve. Notice it's open. That's because the blood is now currently going through that AV valve on its way to the ventricle. That's what's happening in this particular image. But once the ventricles fill up and they start to contract, it's going to shut these AV valves closed, and it's going to push the blood through the semilunar valves, and then basically moving either pulmonary trunk or into the aorta, depending on which side of the heart it's on. Okay. So you can see that basically once you kind of get then the blood coming to the end of ventricular contraction, then the pressure in the blood is going to want to come back down. And what it does, it basically snaps these guys shut, which creates the dub sensation. So once these guys are snapped shut, that creates the dub, the lub and the dub. Okay. Okay, now let's take a look at the control. That's all well and good. Now that we've got the one-way system, right, the one-way flow of blood down in the heart, the real question is now, how do we actually regulate the heartbeat? Well, the heartbeat is regulated because it's got its own internal conduction system. It's an intrinsic conduction system that basically centers around a patch of cells called the SA node. These guys basically refer to, and these are short for, the sinoatrial node. Now, what these guys are, these are muscle cells. These are a special type of muscle cells, and their job is to send out an electric signal, which is the contraction signal, to the rest of the heart. Not only that, but the SA node spontaneously does this. So it spontaneously fires each contraction. Now think about this for a second. The reason why this is a big deal is because usually what happens when a muscle contracts, which is what we're talking about here, it has to be told to contract, right? Normally, who's telling that muscle to contract is a nerve, a motor neuron coming from your central nervous system, your brain, that's telling your muscle to contract. And generally speaking, in the absence of that signal from your brain, your muscles will not contract. Now, this is a little bit different because the muscles are contracting, but the signal doesn't come from the nervous system. There is no nerve from your brain or your spinal cord telling your heart muscles to contract. It is a spontaneous firing of your SA node, which are actually a type of muscle cell that will basically, like a perpetual motion machine, like a metronome. Like once you get a metronome going, it just goes tick, tock, tick, tock, tick, tock. And it just spontaneously goes and keeps firing, like without being told by anything in your brain or by any nerve. It just automatically fires spontaneously from scratch. The only time that ever happens actually in your body. Every other muscle in your body has to be told to contract, but not the SA node. So your heart is on a spontaneous metronome. And so it's oftentimes the one that is setting the pace of your heartbeat, which is the reason why we call this your natural pacemaker. Just like a metronome. Any of you musicians, have you ever played to a metronome? Any of you guys musicians? Or played an instrument where you had to like keep your time signature? You either do the foot thing, right? Or if you ever played to a metronome, you get the metronome going like 4/4 time, and it's like, and that allows you to be able to make sure you're hitting your notes on the right beat, not the upbeat, but the downbeat. And it's the same thing here, right? This sets your pace. And that's exactly what your time signature does in music, right? Whether you're 4/4, 3/4, 2/4, 6/8, whatever, that's setting your pace for which every single note will land. It lands on a downbeat, right? Boom, 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 right? And so that sets your pace, just like this sets your pace. And so it's like a metronome. So what happens is when this impulse fires off, the SA node is responsible for sending it throughout the entirety of the heart. So the first place that basically is going to go, it has to send it to several different things. But one of the places it sends first is a partner node called the AV node. This is atrioventricular. This is basically marking the boundary of the atria and the ventricle. This is also in the right atrium, a little bit in the lower portion of the right atrium, right where the atrium meets the ventricles. But basically, this receives the signal from the SA node saying, oh, okay, I'm going to send the signal on to my people. I'm going to pass the message on. It's like retweeting, right? Taking a great tweet that you like and retweeting it. You didn't actually come up with it. You're just basically forwarding it, right? And so it basically retweets the signal, but then it has to send it to the ventricles. And it sends it to the ventricles by way of what's called the AV bundle, or the bundle of His. And then from there, it'll go through what's called a bundle branch system. It'll wrap around the ventricles and then terminate in small fibers, twigs, if you will, called the Purkinje fibers, which will infiltrate all nooks and crannies of the ventricular muscle, telling the ventricles to contract. The reason why this moves so quickly is because these guys are sending this signal through the gap junctions that connects them all. So they're basically, as soon as I get the signal, boom, it's got off to the races. So you guys hear the signal at the same time. And this is kind of what it looks like. So here's your SA node going to fire off a contraction signal. Well, once it fires this off, it's got to send the signal to a couple of places, right? Number one, it's going to send it to its partner and friend, the AV node, which is a little further down. But notice it's also sending the signal to its own tissue. So this is basically the atria contraction, atrial cells, telling its own atria muscle to contract. It's also sending it to the left atrium to contract as well. So the SA node is sending signals out to a couple of places. The AV node to pass it forward, and also the other atrial cells, both right atrial cells and left atrial cells, to tell those cells to contract so they all contract at the same time, left and right at the same time, okay? So it's basically communicating this out to everybody. You can think of this as sending an email out to a group list. Now then what happens is once it goes to the AV node will send it and move that forward into the AV bundle, which starts off as the bundle of His in the right atrium, and then will cross into, through the AV bundle, into the ventricular septum, where it'll split into what's called the bundle branches. And it has right and left bundle branch. So the right bundle branch will basically wrap around the apex of the right ventricle and the lateral wall of the right ventricle. And Purkinje fibers will basically kind of sneak in and infiltrate all these little nooks and crannies of the inner portion of the myocardial muscle. The left branch will wrap around the left side, doing the exact same thing. These Purkinje fibers will infiltrate and basically invade every nook and cranny. So there's not a single cardiac muscle cell that doesn't hear this contraction signal all at once. Okay. Now then, the reason why you get a delay, and sometimes we cover this in A&P, but a lot of times we kind of skip over it in 1006. But just briefly, the reason why you have a delay between atria and ventricle is because the SA node and the AV node process differently. SA node is fast, so it sends that message out to the AV node very quickly, right? And also to the atrial cells very quickly. So the atrial cells have the contraction message in their ears. They're ready to contract. They're starting to contract. But what happens is the AV node processes a signal a little bit slower. So while it's kind of handling the message, the atrial cells are already contracting. Those atria muscles are contracting, and it's squirting the blood from the atria into the ventricles. At that time, what's happening is the AV is still processing it and still in the process of moving that into the ventricles. So by the time that message gets relayed into the ventricles, the atrial cells have already contracted, and now they're ready to relax. And now you have a wave of contraction that starts to spread throughout the ventricles, and then the ventricles contract, but the atria have already done. Right? So it kind of alternates. That's the reason why it alternates that way. So there's more control. Obviously, since the SA node is automatic, we have to have more control than that, don't we? Because we know that we can increase our heart rate. We know that we can decrease our heart rate. So something has to be able to regulate that. And it's also stimulatory. That is to say that I can stimulate your heart to increase or decrease, can't I? I actually did it by giving you guys a surprise exam. I stimulated your heart rate to increase, or by calming you guys down by creating a very calming atmosphere. I stimulated your heart to decrease. Now, remember, there's two things at play here. There's whether you send the message or not, right? That is the SA node. That's automatic. There's another issue. On top of that is like an accelerator and a decelerator. So how often do you send that signal versus how seldom do you send that signal? That pacing, increasing or decreasing the pace of your heart rate, is something that your nervous system can control. That makes sense? That's what we're talking about with the extrinsic control of your heart rate. So for instance, you have control centers in your medulla oblongata, which is your brainstem, that will allow you to decrease, notice, the heart rate not determine whether or not your heart actually fires, but to determine the rate, how fast or how slow it goes. So you have centers that will speed it up. You have centers that will slow it down. Okay, just like in a car, right? It's either speed up, accelerator, or slow it down, a brake. Hormones can also do this. You also have hormones that can increase your rate or slow your rate down. Okay. So now one way that we monitor heart rate is by using what's called an electrocardiogram. And so electrocardiogram basically is essentially a graph of the electrical changes that are occurring when your heart, your SA node in particular, is sending out these electrical signals to the rest of your heart to contract during your cardiac cycle. Now, generally speaking, when we take a look at an EKG, we have a couple of different waves, right, that essentially correlate with specific things. For instance, the first wave that we see is what's called the P wave. The P wave is stimulated by the SA node, and this is basically when the atria start to contract, triggers atrial contraction. So that's the first one we see. Now, the next one is a complex curve called the QRS complex. And this is basically of the electrical signals that are traveling through the ventricles and also they're associated with the atria. Right? Generally speaking, we usually see the ventricles contracting under the QRS curve, but also we see atrial relaxation. Now, there's not an electrical signaling that goes on with the relaxation, but that's also what's happening at this time. While the ventricles are contracting because of this signal, their stimulation, then the atria are relaxing at the same time. And then the last wave we see is what's called the T wave. This is your recovery of the ventricles. This is basically where the ventricles are relaxing. And so what you see is this kind of like PQRS wave. So here's your normal EKG. So this is basically associated with your atrial contraction. This is where your SA nodes will fire. And then shortly after that, you're going to see that signal traveling through the ventricles. That's the reason why you have this complex QRS peak right here. And then, of course, ventricular contraction along with atrial relaxation because they're doing the opposite things at the same time. And then finally, you'll see the ventricular recovery at this particular point as the ventricles begin to relax and reset themselves. So this is a normal EKG. So you can see it down here. So notice you can see this normal kind of a blip. You can see the P wave typically tends to be fairly small. And then you see this nice QRS, and then the T wave is small. And so typically this is what it would look like. So as long as you see a really good, healthy QRS with a little bit of lead in between, typically that's telling you that you've got a pretty healthy PQRST cycle going on. Now, once you get into something that looks like this is ventricular fibrillation. This is basically cardiac arrest. So generally speaking, a dying heart is not a flat line because there's all kinds of electrical signals going on in your heart as it's dying. And so you're going to be creating peaks and troughs during that process. A flat line is basically something where you don't have any electrodes hooked up to anything. There's literally like no electricity going through there at all. So this is basically where you have your SA node and your ventricle. I mean, there's a lot of dysrhythmia here. So you don't have this nice, clean PQRST rhythm. That's what it means to be in rhythm. And so this is where you get the paddles out and you shock them. And so you shock them because what you want to do is you want to basically restore normal sinus rhythm, which is that normal, clean PQRS T wave. And typically speaking, when your heart starts to get thrown into ventricular fibrillation, which is basically a heart attack, then what happens is if there's a lot of arrhythmia because of it, right? That is to say, this SA node piece is offline, it's kind of fouled up, then shocking it will override the system and reset it. Assuming that everything is fine and that there's not so much damage to the heart that it can't maintain a normal sinus rhythm, then it will be able to sort of shock itself back into rhythm. And that's what you see on the shows when they pull out the paddles. The only problem with those is you don't see a flat line. You see this. This is what you see when you pull out the paddles, not a flat line. Okay. So that's basically what's happening. So the problem is with heart attack and cardiovascular issues is normally what's happening is you're blocking the ability of your hearts to contract, which tends to create connective tissue, scar tissue in your heart, and that begins to block normal function of your heart, especially pathways associated with these rhythms. The reason why arrhythmias are so dangerous is because oftentimes you don't feel them. This is one of those ones where if you get arrhythmic, it's like you're fine 1 second, the next second you just drop dead. You don't feel it. It's not a heart attack. There's not crushing chest pain and chest pressure that happens with this one. It just you're here and then boom, you're gone, right? And that typically is something that happens when you start to have heart attacks, because every time you have a heart attack, that is to say that you have a blockage of blood delivery to your heart muscle. Those heart muscles that are having a shortage of blood delivered to them die. And when they die, they get replaced with connective tissue or scar tissue. And if that accumulates, what happens is that scar tissue can create a barrier to the normal communication pathways that your conduction system has to take. So if you have connective tissue or scar tissue blocking your bundle branch, then that means you're not going to be able to get that contraction communication to your heart. And if that happens to an aggressive amount, then you're literally going to just drop dead. The idea there is that you can shock yourself all you want, but if the scar tissue will not reset that communication system, that conduction system back to normal, because there's too much scar tissue blocking the normal transmission pathways, you can shock all you want and you're not going to come back, right? So that's kind of one of the reasons why you want to make sure that if you do start to get to the point where you're having to, get things like stents and stuff like that, be good, eat well, exercise, do what your cardiologist tells you. You do what your cardiologist tells you, and they will keep you alive for a long while to enjoy with your family. Okay. So cardiology is really good at extending life. So ultimately then, ventricular fibrillation is essentially when your ventricles just kind of get all wonky because all these electrical signals just kind of cause it to start misfiring. And then you can't pump blood that way, right? So if your ventricles don't have this nice uniform pumping, it's just going to be like gurgling and spitting. It's like it's not going to be able to get the blood uniformly out to the body. Okay, and that's what's going to cause a problem. And then of course you defib it by basically shocking it and resetting the system. So that's a little bit of cardiology, right? So now you know how to use an AED. That's what an AED is. It's basically just a portable defib device. Okay. So let's take a look at blood pressure. Spend a little bit of time talking about blood pressure because, well, blood pressure is important. So basically blood pressure is simply put, it's essentially the pressure that your blood is exerting against blood vessel walls. And so what this does, it creates a lot of friction. And friction is a type of resistance, drag, if you will, right? And so if you've ever, ridden your bike in a headwind, or if you've ever gone sailing, or if you even walked around in a pretty stiff wind, we've always kind of like walked into a wind and you're just kind of like, you kind of feel like you're leaning into the wind. It's so gusty that you kind of just lean into it and the wind is like pushing you back. Right? We've all done that one. We've all played that game when we're kids. Well, that's resistance, right? What's happening is basically you're creating resistance. As you push forward, it's creating resistance against you, and that's causing your body to work harder, right? So, which is why it's kind of difficult to, you're kind of like you're just climbing a hill when you're walking in a heavy wind. Same thing's happening in your cardiovascular system. Right. So basically this resistance, which is created by your vessel walls, is creating a headwind, if you will, that your heart has to fight against. Now, generally speaking, your blood pressure is going to be the highest in your aorta. It makes sense, right? Because this is right at the doorstep of the heart. And this is basically where you just came out. Kind of like if you think about it, drinking from a fire hose, right? The highest pressure water is going to be where? Right at the nozzle, right? So you don't want to drink water from a fire hose right at the nozzle. It's going to rip your face off, right? Because it's high pressure. As you get further away from the source, that is the heart, it gets lower pressure and you can drink the water down there, right? So it gets, and that's kind of how it works with blood pressure in your body. Progressively decreases as you move away from the heart. So as you go from arteries to arterioles to capillaries, you're stepping your pressure down. And then ultimately it'll move through the venules and the veins where you step the pressure back up so you can get it back to the heart. And then eventually it's the lowest actually when you get to the inferior and superior vena cava. So what is your pulse? So your pulse basically is a measure of the surge or the pressure of the blood that's in your artery. And what it's doing is it's stretching the arterial walls. And normally we measure this in the radial artery. So those of you guys who have a little wrist cuff, how many of you guys do blood pressure with the wrist cuff? Do you have any blood pressure cuffs at home? They're pretty inexpensive. They're good to have, right? You go to the dentist to get your teeth cleaning. Nobody goes to the dentist anymore, right? What do they use on you? Wrist, a little wrist cuff. That's what most of them use. So that's going after the radial artery, which is the artery that basically goes right along here on the thumb side of your wrist, or the brachial artery, which is this guy right here. So that's the big guy up here. That's a little closer to the heart, right? Usually we like the brachial artery on the left side, but you can do it from either. It doesn't matter, right? Because they're both coming from the brachiocephalic and then into the brachial area, and that's where the brachial artery is. You can also do it in the neck, of course. You can measure your pulse, not your blood pressure. I mean, right? Your pulse, you can measure it in the neck as well. So you just measure your carotid pulse. That's where a lot of people will measure it, or the radial, where you measure it in your wrist. Blood pressure, however, can be measured typically, not obviously, in the carotid, because you have this cuff around your neck. That's not a good thing. You don't want to crush your carotid because you pass out, right? But your brachial artery and off your radial artery. And so generally speaking, when we measure our pulse, we're between 60 and 70. Remember before we said it was on average 70, but there's a range. So you can go from 60 to 80. Of course, if you're exercising, that's going to get a lot higher than that. If you're sleeping, it should get a lot lower than that, right? So as the blood pressure moves through your arteries, this is because of the push that your left ventricle pushes behind the blood column. It's going to push that blood hard through those arteries, and we can measure it with a blood pressure cuff called the sphygmomanometer. Lay that one on your friends if you want to sound all smart and nerdy, right? That's a sphygmomanometer, the blood pressure cuff. But basically here we're trying to measure it from the brachial artery. Of course, a wrist cuff is going after the radial artery. Why the brachial artery? It's not because we really care necessarily about the blood pressure in the brachial artery. The reason why we measure the brachial artery is because this is the closest that we can get to the heart. What we really want to know is, what are the pressures in the heart? That's what we really want to know. But the only way you can do that is if a cardiologist lays you down on a table in a cath lab, threads a device through your femoral artery up to your heart and measures your pressures in your heart itself. Now, that's a little invasive to just take your blood pressure, right? So we can do that, but that would be a diagnostic cath. So generally speaking, what we want to know is, what is the closest measuring point that we have access to that will give us a bit of an approximation of how the overall flow and pressures of blood are in the body, and our brachial artery is the closest one. Okay, that's the reason why we measure that one. Of course, a cruder version is the radial artery as we get down to the wrist, right? So the better is the arm cuff, the less is the wrist cuff, okay? Although the wrist cuff is okay, so in a pinch. So when we take a look at blood pressure, we have two different pressure marks that we're measuring. The first one is your systolic pressure, and this is basically your pressure when blood is being ejected from the heart. This is basically associated with ventricular contraction. This is the big number on the top. Then the diastolic is the lowest pressure point. This is basically when your ventricles are relaxing. So for instance, your systolic pressure is the top number, so it's usually high, and the diastolic is the bottom number, which is usually lower. Okay. And so there is generally a range of blood pressures that we like to keep our eyes on in order to help us determine whether or not you have normal, abnormal pressure. For instance, hypertension, which is basically high blood pressure, hypertension, so large tension, in this case, blood pressure tension, versus hypotension, which would be low blood pressure. So we like to basically have markers for this. We're going to take a look at this here in just a second with a table. So what are we actually doing when we take a blood pressure, for instance, and we measure it in the brachial artery? Well, it's simply this. Basically, your brachial artery and most of your arteries, as the blood flows through it, flows through evenly and smoothly in what's called laminar flow. Laminar flow under a stethoscope is silent. You can't hear it. So if I were to put a stethoscope on over my brachial artery and listen to it, I wouldn't hear anything. Not my pulse. I wouldn't hear anything because it's laminar flow, just moving through whisper quiet, smoothly. Okay. Now what happens is, I'm going to extend this out, is I'm going to crush this brachial artery, not permanently, just close it down, with my cuff by basically wrapping it on my brachial artery, pumping it up, and crushing it down. So what happens is I block the flow of blood. And at that particular point, I put my stethoscope on it and I start to listen. Now I'm going to go ahead and at this point do slow release. A couple of millimeters of mercury per second, perhaps. And as I slowly start to open up my brachial artery, as I release the pressure, what's going to happen is the blood is going to flow through. And as it kind of flows through initially, it's going to backwash, kind of like water in a babbling brook getting all chopped up and sort of getting turbulent flow as it goes over rocks. Okay, so this is what's called turbulent flow. And it's noisy. You can hear it under a stethoscope. It doesn't sound like gurgling, right? It just sounds like a boom. Matter of fact, what happens is once you basically air up the cuff and you listen, you let it, you start to release the cuff, it starts to go down. What you'll start to hear very quietly, this is the reason why it has to be very quiet when you do this, is you'll start to hear this very, very soft sound. Boom, 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 as the pressure goes down, boom, boom, and all of a sudden, boom, it'll disappear. The second you hear it is your systolic pressure. That's when you read it. The second you hear it disappear is your diastolic pressure. That's when you read it. Okay. So what's happening is that bump sound you're hearing is the sound of turbulent flow as the blood is sort of squishing or squirting through that small aperture that you're creating as the cuff releases. And then what happens is once you open this up fully, then you restore laminar flow and it gets quiet again. That's when it disappears. Okay, so that's what's happening. So under full collapse, you have no sounds because there's no blood going through. As it's partially open, you're going to get turbulent flow. That's where you first hear the first sounds of your systolic. And so you mark that point. And then once you hear the sounds disappear, that's your return of laminar flow. And that basically is where you mark your blood pressure. Okay. And so this is kind of what our range of blood pressures we look for. For instance, if your systolic is below 120, typically that's referred to as normal. And if it's below 80, that's also normal in the diastolic range. If you're into the 20s, then it's elevated. Even if you're below 80, that's still kind of elevated. If you're in the 30s, typically we start to move into hypertension range, especially if your diastolic starts to creep up. So now you're moving more toward the 90-ish range in your diastolic pressure. If you're over 140 in the 140s or more, then you're in stage 2 hypertension. So it's a little more aggressive. Oftentimes your diastolic is going up along with it. If you're above 180, then you need to go see somebody because especially if your diastolic is at 120. So bad things happen at this particular point. Now, here's the thing. A lot of times people will freak out. They'll do something stupid, like go to Walmart. And then they'll sit down and they'll do that little blood pressure thing at Walmart, right? And then they'll be like, oh my gosh, my blood pressure's high. Well, of course it's high. You're at Walmart, right? I mean, half the time you just want to punch people when you're at Walmart because that's just what Walmart does to people, right? And yet we can't help it because, well, the prices are cheap and that's the only place half the time that you can afford to shop because everything else is so expensive. But the thing is this, right? I mean, if you basically come in and you want to come into a cardiologist, you measure your blood pressure and it's like about 140 or something like that, and you call your cardiologist, they're going to be like, don't come in. Why? Because blood pressure is not a moment in time. Blood pressure oscillates and varies all throughout the day. Constantly, it is peaking and troughing and peaking and troughing. So normally, even if you call a good primary care doctor and you say, oh my gosh, my blood pressure is 140, a good nurse will basically say, you know what, just relax, take a deep breath. It's going to be okay because the way you're reacting is going to increase your blood pressure, right? So just relax, wait about 10 minutes and take it again and tell me what it is. Oftentimes that blood pressure will go back down because you happen to catch it on a spike, or you happen to catch it while you're at Walmart when you're admittedly stressed because you only have 5 minutes to get everything you need to get out of there. And everybody knows it's going to take at least 5 hours to get through Walmart, even if all you have to do is grab one thing, because that's just the way it works. It's like a black hole for the soul, right? You enter and you never come back out. At least it'll come back out the same. So yeah, you can tell how I feel about Walmart, but it doesn't keep me out of there. So I just keep smearing myself across the Walmart event horizon, which is I think is what that logo of Walmart is, like the little, it's a black hole, right? It's like you enter here and you're going to be sucked into the black hole, never to be seen again, and will smear your soul across the Walmart verse, right? And then we'll sell you to the dark web. But sorry, that was, they don't do that, by the way. I'm just saying, right? Just don't freak out on Walmart. But it's got its own issues, right? But the thing is, a good cardiologist would be like, listen, no, don't call me when you have high blood pressure. As a matter of fact, our cardiologist, when I was working in cardiology office, they didn't treat hypertension. If you had high blood pressure, that was not good enough to make an appointment with them because they're like, listen, your primary care doctor needs to follow your hypertension and they should be able to do this because the cardiologists have to, they have to see people that are having heart attacks in the emergency room, and they have to see people that are in emergency care who basically have to have stents put in like now, or they're not going to be here 10 minutes from now. Right. So those are the kinds of cases that they need to focus on, not something that can easily be dealt with by a primary care physician. But the idea is, remember, blood pressure is constantly peaking and troughing. So if you get a high one, just measure it again, relax, measure it again, and see what it is. When we're talking about high blood pressure, like over 180, we're not talking about like when you're working out on the treadmill, your blood pressure is supposed to be high because your body is trying to get a high demand, right? It's like your body's in high demand. It needs that blood to be sent to it very, very quickly. We don't necessarily freak out about high blood pressure when you're working out because it's supposed to be high. However, if you're taking a nap and it's 180, then we're worried, right? That's when you start talking to your doctor to say something's wrong here. And then what they should do is they take a look at, they should do like what's called a long-term blood pressure monitor, which is one that you wear routinely, and then as your blood pressure increases or decreases, they have you fill out a diary, because the idea is like, okay, so when your heart was here and it went over 180, what were you doing, right? Were you working out? Okay, I'm not worried. Were you taking a nap? Okay, that's a little concerning. So we need to see exactly what you were doing. It's not necessarily what your blood pressure is, it's whether or not your blood pressure is making sense. with what your body is doing, right? So that's a very common thing. We saw that a lot. A lot of patients spent a lot of stressful, wakeful hours when they didn't have to because of blood pressure. And oftentimes the nurse just said, take it again, relax, and just take it again and tell us what it is. And then it turned out to be okay. Even if it is high, it's usually like, you know what, don't worry about it. We've got medication that can manage this. Just come on in. We'll take a look at it. We'll have you on a monitor. If it is high blood pressure, we've got a lot of medications that can keep that blood pressure down. You're going to be fine, right? You're not going to be dying anytime soon, right? So then this is basically kind of a view of how these different parameters look as you start to move through the arterial system. So as we start to move pressure-wise through the arteries and through the arterioles, through the capillaries, through the venules and the veins, you can see the blood pressure basically starts off very high in the arteries. And then as it starts to go through the arterioles, it goes way down until you get to the capillaries. So you can see there's still a little bit of pressure in the capillaries. Again, you need a little bit of pressure to get through the capillaries, but you need to go slow enough to be able to do that exchange, right? That's the newspaper route thing. And then as it kind of goes through the veins, then what's going to happen is the blood pressure continues to drop. The blood flow, the velocity of the blood flow is basically kind of high in the arteries. It goes down. It goes way down in the capillaries. So the blood flow is slow, but the pressure is decent, right? That means the push behind you is decent. But notice the blood flow goes up, even in the face of the blood pressure going down. So a lot of times students will take a look at this and they'll be like, wait a minute, wait. How does blood flow go up in the veins if the pressure is going down, right? Because isn't the pressure like what's pushing you? Well, the reason what keeps you here is those valves. So it's all the tricks of your venous blood system that keeps that blood increasing in velocity, even though the pressure is low, okay? Now, cross-sectional area, which basically means how many blood vessels do you spread around, increases as you get toward the capillaries. So it's very low in the arteries. It gets a little higher, and then it maxes out in the capillaries, right? This basically favors exchange. So lots of surface area for that exchange. And then it goes back down again as you go through the venous system. So the blood flow, which is regulated, is slowest in the capillaries, but it picks up again in the veins. And so it's slowest because this allows you to be able to exchange your gas and your nutrients. And it's, of course, adjusted by those precapillary sphincters, which we saw. Now, the blood flow in the veins is low, but the pressure, or excuse me, is high, but the pressure is low. And the reason is because in the veins, you have a couple of different techniques to increase your blood flow, right? So this basically increases blood flow. Although the pressure is lower. Number one, well, I'll start with number three and go backwards, is the valves, right? We talked about those one-way valves in the veins. That's one way to maintain forward flow, increase your blood flow. The first one is skeletal milking or skeletal pump. Basically what happens is when you contract your skeletal muscles, it'll squeeze on your vein, and that vein will push the blood through those valves, moving it up toward the heart. As you relax your skeletal muscles, it'll try to come back down, but it'll close those valves. And then you contract them again, and it squeezes more blood through that valve, and it kind of keeps going. So as long as you're contracting your skeletal muscles, it'll continue to move that blood by squeezing it, literally by kind of squeezing it all up through these vein valves, okay? This is, by the way, what happens when you kind of get a little bit of a pain in your leg and you start massaging your leg. What you're doing is you're squeezing those veins and you're moving that blood forward to kind of get that blood circulation going in your legs, right? So that's another powerful way to get that blood to move. The big one, however, is the respiratory pump. The respiratory pump basically utilizes the changes in pressure in your thoracic cavity to draw blood up. Into the heart. Basically, it's the same set of physics as sucking fluid through a straw. Everybody's done that, yes? So what you're doing by sucking fluid up in a straw is you're creating a vacuum just above the fluid inside the straw by sucking on it. You're sucking out the air, creating a vacuum. What that does is it creates a pressure gradient. The fluid is high, the vacuum above the fluid is low, which causes the fluid to flow from high to low, which moves it upwards. The same thing is true in your thoracic cavity. As you create negative pressure in your thoracic cavity from breathing, it creates a pressure gradient that causes your blood in your veins to move upward, literally like you're sucking the blood through a straw up into the heart. That's called your respiratory pump. That's the main mechanism for actually moving venous blood against the force of gravity back up to your heart, to your right atrium. Okay. So there's that. So what we're going to do is we're going to start next time with our pulmonary and systemic circuit. And I'm going to head back to the office and keep grading.